Welcome to this Go Diabetes webinar on the Patient Experience Study. We're happy that you're here listening to us today, and I'd like to introduce our faculty. Sherilyn Sion Arnold is the President and Chief Learning Officer of Integrated Learning Partners based in Westport, Connecticut. For the past 14 years, Sherilyn has held senior leadership positions in healthcare pioneering, performance optimization, and e-business solutions. She is recognized for designing award-winning educational research, performance improvement, patient health, and medical education solutions for specialty medical societies, academic centers, and pharmaceutical manufacturers in the United States and globally. Sherilyn is also a performance improvement practice champion for Joslin Diabetes Center. In this role, she provides consulting services to primary care practices throughout the United States, helping them to improve team-based care and implement continuous quality improvement programs to improve type 2 diabetes, clinical measures, and patient health outcomes. Sherilyn, would you please share with us the patient experience study that was done as part of this year's Go Diabetes project?
Thank you, Susan, and I'll be happy to. For today's agenda, I'll be reviewing the Go Diabetes Patient Experience Study project. I'll start by providing a general overview of the project and then talk about some key findings we identified during the baseline survey, survey number 1, and how this information guided the development of the educational interventions. I'll then review some of the project's educational goals and share with you some of the material that we used in the interventions for both providers and their patients. I'll talk about some of the Survey 2 highlights and the impact the study had on participating providers and patients. So let's get started. First, I'd like to introduce you to the study team. The research study team consisted of myself, Dr. Peter Gamache, who is our research specialist, and he worked closely with Dr. Patricia Gilliam, our senior clinical specialist. Dr. Gilliam and I worked on the design of the educational interventions, and Ms. Catherine Griffin worked closely with me on the project management and coordination of the deliverables. Ms. Griffin was instrumental in managing the day-to-day tasks and was a primary point person responsible for the recruitment of this study. I'd also like to add that in addition to Dr. Patricia Gilliam, we had 2 guest faculty members from the Joslin Diabetes Center participate in the provider webinars. Ms. Patricia Bunn Sr., who is a manager of educational programs at Joslin Diabetes Center, and Ms. Sharon Jackson, who is a project manager in clinical research at Joslin. Both possess over 20 years of experience working in primary care and are currently seeing patients. They are working in clinics in the greater Boston area. Regarding provider and patient participation, we had a total of 22 providers participate, representing 8 practices throughout the United States. We also exceeded our goal of 65 patients and had 81 patient participants in the study. Due to attrition and practice staffing changes, we experienced a drop-off at the conclusion of this study. Specifically, due to that, there was some decline in patient participation as well, because with the providers who left their practices, we were unable to keep their patients in the study. The objective of the study was to determine patient satisfaction relative to type 2 diabetes care they receive, and to assess the impact of integrated learning between clinicians and their patients. Our goals were to improve providers' communication skills with patients, enhance patients' knowledge about type 2 diabetes and self-management skills, as well as assess and improve the patient care experience. This slide highlights the timeline of the study design. As you can see, there was a pathway designed for providers and one designed for patients. We experienced some delays with patient recruitments, hence had to extend our timeline through to September. In addition, interventions and follow-up were dependent on patients having scheduled follow-up visits with their providers within a 3-month window. So we had to work closely with the office staff to ensure follow-up appointments were scheduled. Regarding our recruitment goals, we recruited practices between February and March 2012. Our goal was to have 6 practices participate, and we were able to recruit 8. Each practice identified 2 to 3 providers to participate in the study, and each provider recruited about 5 patients. At the onset of the study, we had 22 provider participants. However, due to attrition, as I mentioned earlier, at the conclusion of the study, we had 18 provider participants. Regarding patient recruitment ran from April 2012 through May 2012. The criteria for patient recruitment was that patients had to be greater than 21 years old, diagnosed with type 2 diabetes, seen in the provider's practice for at least 6 months. They had to have no severe comorbidities. We did not accept non-speaking English patients, and they couldn't have a terminal illness. All patients were required to sign a consent form, and as I mentioned earlier, we had 84 participants at the onset of the study, patient participants that is, and then at the conclusion we had 43 patient participants. Let's talk a little bit about the patient recruitment process. The patient recruitment process was a very controlled part of the project. We worked with front office staff at the practices who handed out study recruitment materials and patient consent forms. Then ILP followed up with patients because the patients were actually blinded to the providers. For patient participation, each patient received a $15 gift card to either Walmart or Target when they completed each survey. And to help motivate patients, we incentivized them with a chance to win a $50 gift card for completing both surveys by a set date. And the form on the right is just a sample of the patient consent form that we used. We did develop this form and run it by all the practices who participated to get their approval. Let's just look quickly a little bit about the patient demographics from a race and ethnicity perspective. We had 15% self-identified as African American or Black, 12% Latino or Hispanic, and 3% Asian. If we take out the white population in this sample, the Black, Latino, and Asian populations mirror that of the fastest growing populations diagnosed with type 2 diabetes. And I did want to mention that 64% were white or Caucasian Americans. With regards to age, this also mirrors the trend in diabetes here in the U.S., and the majority of patients were between 41 and 64 years old. The second largest population in this study being older than 65 years of age, which is also a growing population in the United States. I'd like to review the project methodology with you. This project was sequential in that every phase or step related to the next. First, we had pre-survey instruments that were used to assess and qualify practices. Then we had a series of training webinars to review the project before we received actual formal commitment from the 8 practices. We also worked with office staff and participants to maximize recruitment efforts, and formal and informal surveys as well as phone interviews guided the development of the pre-intervention survey, which is Survey 1. Data from Survey 1 guided the development of the educational interventions. The interventions were customized to meet the unique needs of both providers and their patients involved in this study. Intervention formats included print and online toolkits that consisted of one-page fact sheets, guides, brochures from the American Diabetes Association, Joslin, and other healthcare organizations. In addition, for providers, we hosted a 1-hour training webinar in July, and we focused on teaching strategies and tactics that providers can use to improve clinician-patient communications, as well as patient adherence and self-management plans. I'll talk about these a little bit later on in the presentation. Also, to finalize the survey, we designed a post-intervention survey, survey number 2, and this survey was designed to assess the impact that the educational interventions had on providers, looking at a change in skills and practice behaviors. So let's take a look at Survey 1. This slide highlights the key findings at baseline. The baseline survey, or Survey 1, was administered prior to our study interventions. This survey was designed to assess the provider styles and attitudes related to patient education, counseling, and communication. The patient survey mirrored the provider survey, but assessed the patient's perceptions in their experience of the discussions that they had with the providers about diabetes management. In Provider Survey 1, we asked several questions about techniques and specific tools used in practice, and with regards to Provider Survey 1, which I mentioned. We also asked about specific topics that might be included in patient education about type 2 diabetes. Specifically, when we asked about assessing for health literacy, 79% of providers surveyed said they do not use any formal mechanism to assess for health literacy, and 29% only asked their patients about the highest level of education they completed. When we asked providers if they checked if their patients understood the information they provided to their patients about diabetes, 21% of providers said sometimes they check for understanding, and 38% said they rarely check if the patient has understood the information they provided to them. Here lies an opportunity for improvement to help patients improve adherence to treatment plans by just checking to see if they understood the information provided. This aligns to the patient data results that we also saw in Survey 1. When we asked the patients to tell us with yes or no responses if their provider asked if they understood the information or if they understood the information that the provider gave to them, the majority of the patients said no. Another question we asked providers was related to their use of specific counseling techniques. We know that several specific brief interventions and motivational interviewing techniques are frequently used to promote lifestyle changes such as diet, physical activity, or smoking cessation. So we asked providers if they use motivational techniques or any other brief interventions or methods when counseling and educating patients about diabetes, and only 13% of the respondents said they always use them, and 29% use them very often. With almost 50% sometimes to never using them, we felt this was an area of educational focus as we planned the future educational interventions. Now on this slide, this points out major challenges identified by the providers in Survey 1. A list of the challenges were presented for providers to select from. There was also a free-form field for providers to write in other challenges. The top challenges identified were patients are not ready to make lifestyle changes. There's a lack of time for counseling and education, followed by patients are unable or unwilling to adhere to their treatment plans. And lastly, providers indicated that their patients are not, that there's competing priorities during the practice visit. With regards to motivating patients, motivational interviewing can be used to address several of these issues. The technique that can assist them in determining if a patient's values or if it's a new desired behavior change you're looking for, it's also helped to identify if the patient is ready to make changes required in the new behavior. In addition, providers can use probing strategies to improve the patient's adherence to a new behavior. And not to ignore the provider's challenges with time, 95.8% of the providers noted a lack of sufficient time in counseling, but we have to consider how valuable it is for the patient to understand their diabetes and the instructions for successfully managing the diabetes to attempt to address these challenges. So for example, we may want to look at other ways that we could provide information or streamline communications in the exam room and provide tools in the waiting room to elicit and educate patients. Regarding patient survey number 1, some general questions were asked include, did the provider spend enough time with you during the visit? Did the provider listen to the explanations and questions carefully? Did the provider answer your questions to your satisfaction? What is the degree of trust you have with this provider, and how would you rate your overall experience with the visit of this provider? Lastly, would you recommend the services of this provider to your family and friends? Only 2 of these questions were yes or no responses, while the rest were measured using a 5-point Likert scale. The overwhelming majority, over 95%, rated that their providers rated the providers with the highest positive response. So they were really pleased with the relationships and the communication they had. Generally speaking, however, patients felt that their providers were doing a good job, but they didn't necessarily understand all the information that was provided them, specifically with regards to their diabetes care. And so this slide lists some of the patient challenges that the patients either selected from or wrote in the open text fields. The challenges that are bolded were selected by more than 80% of the patient participants. I found it challenging to accurately explain my diet within the past 3 months when asked. I found that the diabetic diet is too hard to follow. I've not been able to afford home diabetes testing equipment, such as meter strips. These are just some examples. While a fairly large number, but not the majority, said by selecting the third response, I do not always understand things my clinician is telling me, they noted that they were not able to understand the medical words related to diabetes or use of medical jargon, which we teased out. So a focus of the guided educational interventions included looking at communication skills and not using medical jargon when talking to patients, using teach-back methods, and developing SMART goals that were understood by the patients as well as attainable. Now I'd look to talk about the educational focus. We were very privileged to have both Ms. Monsignor and Ms. Jackson participate in the educational intervention with providers, and they both emphasized the effective communication is the foundation for all diabetes self-management. However, the question is, how do we do it? After analyzing data from Survey 1, we shared this information with our identified knowledge gaps and disconnects between the providers and what they intended to say and what the patients actually heard them say with Ms. Monsignor and Ms. Jackson. We had several planning sessions to lay out the focus of the educational interventions, and the topics that demonstrated the greatest areas of educational need included improving provider-patient communication skills, assessing patients' health literacy, counseling patients on lifestyle changes, specifically nutrition or physical activity, medication adherence, and blood glucose monitoring, in addition to improving patient adherence to self-management plans. One of the most important skills we focused on was the teach-back method. We felt this method was important because it was a way for providers to assess the patient's understanding of any information that was presented, taught, or discussed during an office visit. As you may know, the teach-back method is asking patients to repeat in their own words what they need to know or do, and in a non-shaming way. It is not a test of the patient, but of how well you explained the concepts. And it is an opportunity to check the patient's understanding and, if necessary, reteach the information that you're providing. This slide highlights a few examples of how providers can use the teach-back method. Some open-ended inquiries providers might want to consider using are, I want to be sure I explained everything clearly. Can you please explain it back to me so I can make sure I did? What will you tell your husband about the changes we made to your blood pressure medications today? We've gone over a lot of information, a lot of things you can do to get more exercise in your day. In your own words, please tell me what we talked about. How will you make it work for you at home? Some of the key things to remember is that the teach-back allows providers to check for understanding if necessary and reteach, as I mentioned earlier. It's important not to appear rushed, annoyed, or bored during these efforts because your affect can also affect how your patients respond to this method. The training materials for the providers were designed using the 4 pillars of diabetes self-management. Here, with the educational materials and in the training webinar, we reviewed strategies and tactics that providers can use to improve their counseling skills of patients about nutrition, physical activity, medication adherence, and blood glucose monitoring. With regards to the educational interventions designed for providers, they were launched between June and July. The first consisted of the one-hour training webinar where we focused on communication techniques, lifestyle counseling, and teaching providers how to set SMART goals with their patients. In addition to the training webinar that then was open for Q&A, we provided the providers with a toolkit, a selection of patient assessment tools, staff training resources, and patient education materials. Some of the items also included in the toolkit included the communication self-assessment tool, information about improving cultural competency, helping patients make and sustain healthy changes to motivational interviewing, physical activity prescription forms, and team-based training tools. We also provided links to suggested CME activities and sent copies of the patient education tools that were sent to the patients. Patient educational interventions were rolled out in June. Many of these materials were print and web-based. We did customize the packets for each patient based on their preference that they indicated in Survey 1, whether they had access to the Internet or appreciated receiving print materials versus online. Some of the materials in the toolkit included the blood glucose monitoring handout from Joslin Diabetes Center, a food and activity record log, making healthy choices and guidelines, how to eat better on a budget, 10 tips to help you stretch your food, and a Joslin foot care handout. All of these are in the public domain and were free. Many of the materials came from organizations, as I mentioned earlier, like the American Diabetes Association, Joslin Diabetes Center, and the United States Department of Agriculture. And we received positive feedback from the patients and follow-up phone surveys that they really were able to use these materials that actually were sent to them on behalf of their practices, and they did take materials like the My Diabetes Care Plan or Making Healthy Food Choices or their activity logs to their patient follow-up visits. Now let's take a look at Survey 2. For what we're going to do is talk a little bit about the highlights that we found. Let's start with the providers. With regards to asking providers if they are more likely to use formal tools to determine if their patients determine the patient's health literacy, 91% of respondents said yes. This is a significant commitment statement given that the onset of the study, only 10% of providers indicated that they assessed for health literacy. Assessing for health literacy is critical in understanding patients' functional literacy as well as numeracy levels with managing diabetes. It's imperative to their success in understanding and attaining their self-management plans, so we were pleased to see this. In addition, we wanted to assess the provider's commitment to using patient education tools with patients during exams, and 91% of the providers indicated they would integrate the use of tools into the patient examinations to help with time issues. It was suggested that they have select copies of the patient handouts in the exam room so that they could easily refer to them at the point of care. Others talked about implementing these tools into their EMRs and having staff manage these resources in the exam and waiting rooms. In Survey 1, 61% of the providers indicated that they could generate patient education tools from their EMR, but 53% of those providers stated that such patient education tools were not useful. So our goal was to work with providers on how they can enhance access to patient education tools in their practices. 80% of providers stated that they would make a favorites folder for patient education materials, and the same 80% stated they would add the Go Diabetes Patient Experience Study education materials to their EMR. While others are not on an EMR, as I mentioned, they would print out the materials and have them available in their exam rooms, as you can see here. I put this slide in because it demonstrates that as a result of participating in the study, 90% of providers are going to assess patients' knowledge prior to setting self-management plans, as well as assess their patients' readiness to make lifestyle changes. These are techniques that were not being used prior to the educational interventions that were self-reported by the providers, and they are critical factors in identifying potential barriers relative to meeting helping patients meet self-management goals. Providers were also taught how to help patients set SMART goals and assess the readiness for change. In addition, faculty reviewed how they can effectively use the teach-back method and strategies to assess patients' understanding of specific information, and it's really great to see that 80% of the providers plan on using this technique as well. This slide depicts a change in confidence levels as a result of participating in the study. What was nice to see is that 60% of the providers noted there was a significant change in their confidence levels, specifically as it relates to motivating patients to adhere to diabetes management plans. In addition, 40% of providers indicated a significant change in their confidence levels relative to assessing the patient's understanding of new concepts regarding diabetes and the diagnosis and meal planning. It seems that providers' confidence levels increased in discussing meal planning with patients, and that this did have a direct impact on the patients, because in Survey 1, patients stated that they didn't have a good understanding of meal plan and that it wasn't often discussed with them. And now, after participating in this study, patients indicated that their providers are talking about meal plans with them. So this is a great start. We also put this slide in because in Survey 1, patient results indicated that their providers were not talking with them about foot care. And even though provider survey results indicated they were, now as a result of participation, patients noted that their providers are talking about the importance of routine foot checks with them. We feel this correlates back to the teach-back method training providers received, where examples were given specifically about foot care, about showing patients how to perform foot checks and the importance of doing them frequently. They also talked about using compact mirrors or dental mirrors to help look at the bottom of their feet, and some of the providers actually indicated that they use these in the exams and teach back with the patients. We also asked patients if providers were using the teach-back method during their last follow-up exams, and 50% of the patient participants said yes. So we're hoping that this will continue, as data suggests that using the teach-back strategies or techniques does help improve patient engagement and adherence. We also wanted to assess if patients found the GoDiabetes Patient Experience Study Toolkit materials useful, and more than 80% found them useful to very useful. I'd like to add that the print material, specifically the 1 to 2 page fact sheets with diagrams and the patient food and activity logs, were most preferred by the patients. And lastly, we wanted to know if there was an increase in the provider-patient dialogue after participating in this study, and more than 90% of patients responded that they are having more extensive dialogues with their providers about their diabetes self-management plans, which secondarily is resulting in improved patient experience and satisfaction with quality of care they are receiving. So to that end, I'd just like to say that the providers started off doing a great job. There was good trust and relationships built with their patients. At preliminary review of Survey 2, the provider and patient data, they were doing an even better job. So I hope that the progress continues, and this is really all part of a continuous improvement process that I hope will continue long after this study. So with that, I'd like to thank everybody for their time today, and I'll turn the baton back over to Susan.
Thank you so much, Sherilyn. That was very informative. And for the GoDiabetes participants who enrolled in the patient experience study, I'm sure you're going to find this fascinating. But additionally, it's useful information for those who are working to improve care for all of their diabetic patients. At this point in time, we can have questions. The questions will be asked using the chat function, as we have done in previous webinars. And if you would like to ask a question at this point in time, just use the chat function, and I'll read those out loud, and Sherilyn can then answer them. Please note that this webinar has been recorded. It will be posted on our GoDiabetes website, the address www.godiabetes.org. And we'd be available for you and for your colleagues if you'd like to listen to it under the Resources tab in our website. All of the webinars that we have given have been recorded and are available for your viewing and listening interest. At this time, we don't have questions. I think Sherilyn was quite thorough with her presentation. I'd like to thank you once again for your attention, and this ends the webinar.